Prevalence of disease. Consider this problem that was posed to a group of Harvard doctors. The problem originates from a 1978 article in the New England Journal of Medicine, Castells et al. See further information. If a test to detect a disease whose prevalence is 1,000 has a false positive rate of 5%, what is the chance that a person found to have a positive result actually has the disease, assuming you know nothing about the person's symptoms and signs? Assume the test generates no false negatives and take a moment to work this out. In this problem, we have removed clinical probability and are only considering prevalence. The answer is at the end of the chapter p. 11. Predictive values combine sensitivity, specificity and prevalence. Sensitivity and specificity are characteristics of the test, the population. Does not change this. However, as doctors, we are interested in the question, what is the probability that a person with a positive test actually has the disease? This is illustrated in box 1.5. Post-test probability and predictive values are different. Post-test probability is the probability of a disease after taking into account new information from a test result. Bayes' theorem can be used to calculate post-test probability for a patient in any population. The pre-test probability of disease is decided by the doctor. It is a judgment based on information gathered prior to ordering the test. Predictive value is the proportion of patients with a test result who have the disease or no disease and is calculated from a table of results in a speci-C population, see box 1.5. It is not possible to transfer this value to a different population. This is important to realize because published information about the performance of diagnostic tests may not apply to different populations. In deciding the pre-test probability of disease, clinicians often neglect to take prevalence into account, and this distorts their estimate of probability. To estimate the probability of disease in a patient more accurately, clinicians should anchor on the prevalence of disease in the subgroup to which the patient belongs and then adjust to take the individual factors into account. Dealing with uncertainty. Clinical NDs are imperfect and diagnostic tests are imperfect. It is important to recognize that clinicians frequently deal with uncertainty. By expressing uncertainty as probability, new information from diagnostic tests can be incorporated more accurately. However, subjective estimates of probability can sometimes be unreliable. As the section on cognitive biases will demonstrate, see below, intuition can be a source of error. Knowing the patient's true state is often unnecessary in clinical decision-making. Sachs and colleagues, see further information, argue that there is a difference between knowing that a disease is present and acting as if it were present. The requirement for diagnostic certainty depends on the penalty for being wrong. Different situations require different levels of certainty before starting treatment. How we communicate uncertainty to patients will be discussed later in this chapter, see Fig. 1.9. The treatment threshold combines factors such as the risks of the test and the risks versus benefits of treatment. The point at which the factors are all evenly weighed is the threshold. If a test or treatment for a disease is effective and low risk, e.g. giving antibiotics for a suspected urinary tract infection, then there is a lower threshold for going ahead. On the other hand, if a test or treatment is less effective or high risk, e.g. starting chemotherapy for a malignant brain tumor, then greater confidence is required in the clinical diagnosis and potential benefits of treatment RST. In principle, if a diagnostic test will not change the management of the patient, then careful consideration should be given to whether it is necessary to do the test at all. In summary, test results shift our thinking, but rarely give a yes or a no answer in terms of a diagnosis. Sometimes tests shift the probability of disease by less than we realize. Pre-test probability is key, and this is derived from the history and physical examination, combined with a sound knowledge of medicine and an understanding of the prevalence of disease in the particular care setting or the population to which the patient belongs.